No, I do a pretty thorough consent before they go into surgery. If you say, I'm going to do a triple arthrodesis on you, you're getting a lot of quizzical looks, and so you've got to, obviously they know they've got pain, and I point out to the x-ray, what's going on, and usually they've been referred in by another physician. So I end up getting them after the, other conservative therapies have failed and coming in for the reconstructive surgery. Good question. Oh, another video perhaps, huh? Or are we just hung up?
Dr. Davis?
Yes.
I have a question. Some of us have a spine background, and so this is a new world for us. What are some of the analogies, or what would be analogous between spine and the foot? They're both very complex structures, but in terms of healing times, and instead of weight bearing, maybe the ability to just be stable and be pain free. How do some of those things tie together?
I'm glad I'm what I am, because I don't envy the spine guys. They've got, but I'm not so proud that I won't steal from anybody. And so the cervical plates, I've been using those for years. Richard can tell you, long before anyone ever actually came out with a fully locking, variable angle plate fixation, because I realized that those guys had the good stuff and they were giving me garbage. And so I take from any surgical specialty, and so I'm using cervical plates in my foot surgery. These are EBI or Biomet View-Lock plates. They're locking, and again, they give me a choice of angle. So I take from them, but none of them have actually taken anything away from me as far as technology goes, because I've been using the platelet-rich gel when they were starting to use the platelet-rich gel, and so the stuff that I learned about that works well in other specialties works for me too. Like I say, I've been using stem cells for 3.5 years in foot and ankle surgery. I don't know anybody else who's been doing it that long, So I take those type of technologies. You're walking on the foot. Of course, the spine is load-bearing as well, but it's further upstream, so there's a lot more force going through the foot, so there's a lot more technical difficulties, which is why I've got this particular construct. But they have a far larger void to fill. When you take a disc out and you try to decompress that nerve, you have to open up that space again. So that's why you see them, if you see their x-rays, are not as impressive as mine, but they're thrilled because they're seeing a little bit of bone forming in between those two things at 12 or 13 weeks out. But that is a big deal, because it takes a long time for those things to fuse, because they've got gaps about yay big that they're trying to build bone across. Does that answer your question?
Yeah, it does.
Alrighty. BG. Okay, yeah, Bessie. 3 weeks out. Hopefully the screen will go white again soon, because I know you're tired of looking at these type of things. You probably can't see it anyhow, but that's 5 weeks, and that joint's fused. Okay, we're recording now, Bessie. About what procedure did you have?
A triple arthrodesis.
And about how long ago did you have that done?
10 weeks.
10 weeks ago. Which foot, by the way, did you have done?
Left foot.
How's it feel?
Great.
Well, great. And how long have you been walking on the foot after surgery?
First week.
So you've been walking on the foot now for 9 weeks?
Yes.
And when did we get you into shoes?
2 weeks ago.
Perfect. So about 8 weeks after surgery, you started wearing tennis shoes after your triple arthrodesis. Is that right?
That's right.
And you're not having any troubles?
No.
Fantastic.
No troubles, no troubles.
Thank you very much.
You're welcome.
I appreciate it.
So does it seem like more women have these kind of complications? Because most of your cases are women.
Women are a lot easier to treat.
Yeah.
And they heal better because they listen to what you say. No, really, it's true.
What?
Women-only practices. Sorry, guys.
What did he say?
It wasn't important. Don't pay attention. Is that beer you've got back there?
It is. That's what I thought too.
He's the second person.
Actually, I see it more in women because, and here's why. Because women, I don't know if there's a difference in collagen makeup. I'm sure there's, because hormonal influence definitely happens, and at a certain period of life, those tendons aren't as strong as they used to be. And so as a result, what happens is this: the posterior tibial tendon, which is the main tendon in your arch, fails. And when that fails, the arch collapses. If you've ever had this happen to you, or will have in the future, or know somebody, get them treated right away. because they'll continue to walk out, they'll hurt on it, this is going to feel. Next thing you know, well, my arch isn't as high on that foot, and it begins to collapse, and those joints become, at the end range of motion, you got a lot of shear and strain inside the joint, you lose cartilage, it becomes arthritic, and then the next thing you know, you've got something that's beyond salvage, and that's when you go to the fusions. So perhaps I see more dysfunctional posterior tibial tendon in the female subgroup, and as a result, I see more of that. But there are, you did see a few men here too. Equal time. This was a female, okay, so this is a diabetic, 50-year-old type 2 collapsing Charcot foot. And I say Charcot because you're beginning to see the bone just disintegrate through here. But she wasn't so neuropathic that she couldn't feel pain. She felt a lot of pain. So it was becoming arthritic. This is the, oh crap, collapsing. You saw it briefly. So Deborah?
I used the crutches from a now.
Okay. What procedure did you have?
A triple something.
Arthrodesis?
Arthrodesis.
And about how long ago did we do this?
1 month.
1 month. Okay, great. Can you go ahead and turn around and walk away? How does it feel?
Okay. Better than it was.
Good. Fantastic. Well, thank you very much.